Friends, welcome to my workplace at Ranaghat, West Bengal, India. Let us observe this minimally edited surgery. This is an intumescent cataract, and we will see double Rhexis, we will see submarine chop, and we will see use of coaxial IA versus Simcoe cannula in this case. By this time, on main incision and a side port has been made, and now an air bubble is injected to fill up the anterior chamber, and then trypan blue dye is applied over the anterior capsule. Don't inject too much dye, just enough dye to stain the anterior capsule. And now inject a bit of adrenaline to maintain the dilatation of the pupil, and then wash the dye out of the anterior chamber. And now fill up the anterior chamber with visco. And now I am going to do a small Rhexis first, which I call mini Rhexis, and when you use only HPMC in intumescent cataracts, you may call it Mohanta's mini Rhexis. And now one small Rhexis has been made, and now I am going to use this opening to introduce a 23 gauge Simcoe cannula and aspirate some cortical lens matter. The clockwise and anti-clockwise rotation of the nucleus is done, and all possible cortical matter that comes to the aspirating tip of the Simcoe cannula is removed. Now the anterior chamber is filled up with 2% HPMC again. Then a Vanna scissor is taken and a small nick is made at the margin of the mini Rhexis. Utrata forceps is taken again, and this small Rhexis is enlarged to an optimum sized Rhexis of about 5.5 millimeter. And now let us observe Mohanta's submarine jaw. Visco, the phaconeedle goes with its bevel down. The phaconeedle is introduced into the anterior chamber with its bevel down. Some epinuclear matter you can remove, and then the tip is buried in the substance of the nucleus, and it goes through the substance of the nucleus like a submarine, and you get a very nice crack. 90-degree rotation, hold on heminucleus and crack it. Other heminucleus is also held and divided. We have got 4 pieces in no time. And now emulsification of the pieces is done. I am using 80% ultrasonic energy in continuous mode. Flow rate is 45 ml per minute. Vacuum is 450 millimeter of mercury. And now watch the contact lens concept for the last piece. Hold the epinucleus, detach the epinucleus, and support the epinucleus with the chopper, and this epinuclear shell protects the PC during emulsification of the last piece. And then the epinuclear piece is removed with low vacuum and low flow rate. And now I come out, there are a lot of cells sticking to the posterior capsule. Inject visco, and now I have asked for coaxial irrigation aspiration. And now see what happens. The coaxial irrigation aspiration is a good instrument for when there is lot of cortex, but here there is very thin cortex, and what I do is I hold the posterior capsule and I have almost detached, I hold at another place also. So, in this case this coaxial IA is not a safe instrument. I inject visco and I take the Simcoe cannula and very gently I can remove the cortex by tangential, slow tangential movement. And this kind of delicate movement is almost impossible by the coaxial irrigation aspiration. That is why I say that Simcoe is a very safe instrument. Now, I go through the side ports. The side port is 90° away from the main wound and it's about 1.7 millimeter in width, and it reduces some amount of astigmatism induced by the main wound. And now is the time to implant an intraocular lens. Hydroimplantation of this is use of irrigation probe to release the cells from the posterior capsule. The cells that were attached to the posterior capsule is released, and now this is hydroimplantation of the intraocular lens. The lens goes in the capsular bag. And now this is the final stage of the surgery. I am using bimanual irrigation aspiration to remove some cortex that is there at just in the subincisional area. And now the side port is to be closed. Before that, this is some bit of moxifloxacin injected into the anterior chamber, and now the side port is closed by corneal stromal hydration. And now this is the final lavage of the anterior chamber. The anterior chamber is nicely formed and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.